Welcome to this Autism Ontario Ask the Doctor webcast with ASD expert Dr. Wendy Roberts. This is the second in a three-part series aimed to educate and inform. My name is Matthew Lay and I will be your host for tonight's broadcast. As advertised, tonight we aspire to cover everything you ever wanted to ask your physician about Autism Spectrum Disorder, ASD, and hopefully we'll cover a lot more. Dr. Roberts will speak to early signs of ASD, when and how to make a diagnosis, early intervention strategies, and the medical problems and complexities associated with the disorder. We'll also review competence building at all stages, as well as various communication strategies. Before we get started, I've got a few housekeeping items that I need to handle. To my left, you will see slides. They will change throughout the broadcast and will reinforce the discussion that Dr. Roberts and I will be having this evening. On the bottom of the interface, you're going to find a resources tab. Now, we're going to refer to this often because there's a number of resources located there, both links to websites and documents that once again reinforce what we're talking about and are there to really assist you. There's also a more elaborate version of tonight's PowerPoint found in the resource section. You'll notice there's an Ask Question box that's open at all times. We will be pausing throughout this presentation to take your questions live with Dr. Roberts. So as we go, anything that comes to your mind, feel free to enter it there. Now, there's a lot of people online, and we have a lot of content to cover. And as such, we won't be able to get to all of your questions live here tonight. But Dr. Roberts and Autism Ontario have committed to getting FAQ back to you as part of the follow-up from this event. So don't fret if your question isn't answered live. Finally, there's a help button. Use that if you run into any issues with the broadcast this evening. So with that out of the way, I'm very pleased to welcome Dr. Wendy Roberts to the desk. During her career as a developmental pediatrician, Dr. Roberts has been an active participant in a variety of clinical research projects relevant to the goals of improving the care for individuals living with autism. Her main role in research has been as clinician collaborator and site principal investigator on a variety of projects related to defining the etiology, refining the definition, and searching for intervention strategies for autism. Dr. Roberts, thanks so much for taking time to be with us here today.
Oh, it's a delight to be here. Thank you.
So we've learned from experience that we have a very diverse audience out there watching the event. As such, I want to start with a study that it hits close to home for you. It's the Baby SIB Studies in Autism that informs a lot of the content that we're going to discuss today. Can you talk a little bit about the study and what it entailed?
Sure. Well, this is a study we started just about 13 years ago now at Sick Kids, first with Sick Kids Foundation funding, and it was led by Lonnie Zwagenbaum and Susan Bryson, and Isabel Smith out in Halifax, and Jessica Bryan here with me in Toronto, and Peter Zupmari in McMaster. And we really wanted to understand what the very earliest signs of autism were, and so we needed a population of children who would be at the highest risk of developing it. So we ended up saying, well, the group would be the brothers and sisters of kids with autism, because at that time that's what we recognized, that at least 5 to 10% there would be a higher a reoccurrence of the autism that was happening in the first child. So by now we have studied 200 control children where there's no family history of autism, and we have over 550 siblings who we have started to see somewhere between 6 and 12 months, and then again at sometimes 15, always 18, 24, and 36 months, and now we have our 5 and now close to 10-year follow-up data. So it's been a very, very exciting study, and we've learned so much from living with the families as they watch their little ones grow up.
Wow. With all of that data, I understand you didn't even mention it, but this has gone beyond the Southern Ontario. This has gone international even.
Right. There are now centres, there's at least 17 other centres across North America that have formed a baby siblings research network, and there's a site in the UK, there's a site in Israel. So there are many people around the world now doing this kind of study.
I know most of our content relates back to the study, but with all of that data and clearly over a decade of time invested, what are the high-level findings of the study?
Well, the first thing was that we could start to see things as early as a year, and we'll talk a little bit more about that. The other thing that just came out recently was the recurrence risk, because we now have enough families to be able to say if you have one child with autism, your overall recurrence risk is 18.4%. Interestingly, if you break that down, and this was information we had no idea about before, it was 25.9% in boys and 9.6% in girls. Wow. So you have a higher chance if you have a boy as a second or third child once you've had one. Mm-hmm. So those are, I think, the biggest issues, apart from the behavioral things that we've seen and now some of the early intervention studies we're doing.
Okay. So a reminder to everyone watching online that the resource section holds information on this study. And so if there's anything that you want to dive in further as we're discussing or later on, you can go there to find it. Part of what came out of the study, as you mentioned, is that early diagnosis of ASD is very important. Now, this probably makes a lot of sense to you as an MD. For me, who's not. Can you elaborate on why you think it's so important for early diagnosis?
I'm not worried so much about giving a diagnosis, but we are really worried about seeing red flags or risk factors early, because there's more and more evidence accumulating that if you intervene when you see the red flags, even before a year, we're told, you're more likely to actually be able to influence how the brain is developing and prevent certain pathways from getting established.
Okay, so we got a lot of parents on right now, so let's focus on some information that parents and clinicians in the audience might be able to use to assist in early diagnosis. And I want to start, I think you break it down into 4 or 5, but let's start with social communication. What red flags are we looking for there?
Well, I think that the big thing is, what we noticed first was children who didn't seem as interested in faces anymore. And people think about eye gaze, but it's not so much did they look at you or not. It's more do they use eye contact to engage with you in some way and to show interest, to smile at you, to see that you're looking at them and smile back, to anticipate what you're going to do, to follow a point if you point to something, or use a point to get you to look at something. And an overall sort of expression of, I'm happy to see you, I wonder what you're going to do. And facial expressions change so quickly in milliseconds to reflect that kind of social interest. That's what we see often gradually diminishing between 9 and 18 months.
So it was there before and it goes away?
We see it at 6 months.
Really?
Yeah. In many kids.
And for a child that is not in the spectrum, that should be starting at 6 months.
Intensifying. It starts before that, but it intensifies from 6 months on, because there's more awareness, cognitive awareness that, hey, this person could be fun to interact with.
Okay. Toddlers spend most of their time around toys, so I understand that watching their play with toys can inform a lot. What red flags should we look for there?
I think a child who's using a toy in a different way, so listening more to the sound it makes, doing the same button over and over and over, watching the wheels go around or driving it around in exactly the same way over and over, holding it up close to look at it, like what are they looking at? That's not what most kids see when they see that fire truck. Right. So it's any unusual play.
What do most kids see when they see that fire truck?
Most kids hear the siren and they start to run it around, and they want the lights to be going.
Okay. So toy play rolls right into motor development. So what are the signs that we're looking for there?
It's only recently that we've been looking at that in autism. I don't think when we started out, we were aware, because most kids were walking within the expected kind of times. But what we see is more motor planning difficulties, just looking a little bit unusual or uncomfortable or a little awkward with the way they would try to do things, whether it's holding a crayon or manipulating a hammer or something. So it's getting the message from the brain to the hand quickly enough to make it look as well coordinated as their peers. So I think that relates to the motor planning around the speech muscle use as well. So it's motor planning.
Okay. I understand a lot of kids have specific sensory interests. We've talked about, smelling of flowers, whatever it might be. But this is also a red flag in a certain way. Can you discuss that a little bit?
Yeah, all children like to discover senses, as you say. But if a child has some very intense interest, so lots of kids like to twist their mother's hair or do something, rubbing their skin, especially when they're relaxing to go to sleep or when they're breastfeeding, whatever. But if you see a child who really is agitated in order to get skin to feel, we had one boy we couldn't assess unless his mother wore very long sleeves and long pants, and there really was just about, sometimes she would stand with her hands behind her back so that he couldn't be distracted by wanting to feel the skin on her hands. If we could get that all covered, we could get him to sit at the table and do things with us. So it's the intensity of a sensory interest. Some kids have to smell every single goldfish before they'll put it in their mouth. So things that look unusual in the frequency or intensity.
Okay. This is a good time for me to remind our audience that we've got a more elaborate version of your PowerPoint on the website, and in there is specific developmental flags for both 6, 12, and 18 months. Okay, so what the audience should be seeing now or soon is a slide that has, it's titled ASD Symptom Trajectories, and it's a graph. Can you advise exactly what we're looking at and briefly explain what the graph is giving us?
So this may be familiar to some people in the audience, but the right-hand column shows you diagnostic categories from autism through Asperger's, non-ASD sibling, and non-ASD control. So those are diagnostic categories assigned at 3 years when we have a completely blind assessor come in and review from scratch all the diagnostic criteria, not knowing anything about what we have been seeing over the 3 years. And then they assign that category. When we go back to what we've seen at 6, 12, and 18 months, and we use the AOC, which is a tool developed by Dr. Susan Bryson out in Nova Scotia and the group, the Autism Observation Scale for Infants. When we look at the scores on the 6-month level, you can see that there's a clustering around 7 down to 4 across the 4 groups, but not enough to statistically really separate those groups out very well. But then when you look at the lines, say the red line for autism, that score that's kind of close to the others at 6 months goes quite a bit higher, and then at 18 months goes even higher. So there's a progression of red flags from 6 to 12 to 18 months. That child is on an autism trajectory, and that trajectory we have found stays pretty typical from then on. Then you have the group at 6, 12, and 18 months that are kind of high. They're around 7, so it's just borderline for where our cutoff is, and it stays up there. They don't really vary. Then the green group is the rest of the sibling group who do not end up with any autism-related diagnosis, and the black line is the 2 or 3 maybe little quirky things that every child will show here and there, but doesn't constitute any worry. So we see a really clear demarcation. There's something different about some of the siblings, and they're different from the controls, but there's a clear group that go on to have autism, and we can see it happening by 12 months and being quite clear by 18 months.
And this is, again, data from the BabySib study.
It's all from the BabySib study, and we're now sort of finding out what's happening to the orange group as we see them as they get older, because many of those children who were just borderline in terms of reaching the diagnostic category at that stage and sometimes didn't, as they've gone on with the developmental challenges and the anxiety and all the things that come as they get older, may actually bring out symptoms that will meet an ASD criteria.
Okay. So this is obviously very helpful information. But all of these toddlers were dealt with by the specialist, like yourself. There's a bunch of people asking questions right now. All of early questions are very interesting. But before I ask you those ones, I got to ask, how is it really complex to diagnose autism? Is it a hard thing to do?
You have to know what you're looking for.
Right.
So the big thing is that you make a diagnosis of autism in the younger children based on the absence of things.
Right.
You make a diagnosis later based on the presence of things, the presence of narrow interests and repetitive behaviors and the flapping and the running around in the more severely affected kids that everybody thinks, oh yeah, that's autism. Yeah. Those often aren't apparent or clear until after 3. But in an 18-month 2-year-old, it's the absence of pointing to get you to look at something for fun. It's the absence of turning when their name is called. It's the absence of doing pretend play. It's absence that determines making the diagnosis. But they also, for something like pointing and showing, you have to have the ability to understand the concept of joint attention. You and I can both look at that thing. If I good response, if I make you point. So If you're not cognitively able to understand that yet, then the absence of that doesn't mean anything diagnostically. So you have to have reached a certain level of brain development before you can say that's missing.
Okay. So here's a loaded question. We've had it 3 or 4 or 5 times already. You've done a lot of work. We know a lot more. It's still very complex to diagnose. Is autism really getting more common?
Well, it's a very interesting question, and we'd all love to know that answer. It honestly appears that it is becoming more common. Good epidemiological data is showing more and more. There's no doubt that a lot of the increased incidence is because we are recognizing kids that otherwise might have fit into an ADHD category, a learning disability category. For some of the lower cognitive, more cognitively impaired people, they would have been in the old mental retardation category, now developmental disability. So some children have changed categories, but all that being said, there has been a steady increase using the same methodology over the last few years in some of the epidemiological studies. So we have to consider that it may be.
Okay. I got a strange question here that may mean something to you, it doesn't to me. Is autism related to Uncle George being late talking? Because he's a lawyer now.
That's a wonderful question. So we very, very often get that question. There is quite a bit stronger incidence of late talkers, even no sentences till they're 4, and then many of those individuals will take off and they'll be lawyers or doctors or whatever. However, in the families of people with autism, you will see a higher incidence of late talkers. So if I hear that extended family has a history of late talking, I'm saying that's a risk factor for autism.
Red flag too. Okay. You referenced, or I know about, there's this 18-month visit in Ontario, which has become, it's now been defined. And what should parents expect from that 18-month visit? Why do we do it at 18 months?
So the province of Ontario had an expert panel to look at how to identify kids early and to use all our knowledge and really translate it into practice. And they felt that 18 months was the last chance, if it hadn't been picked up, for a family practitioner, a nurse practitioner, to really look closely at development and say, I think there are red flags for a language delay, a developmental delay, or an autism. Those are the 3 main groups, or a motor delay such as cerebral palsy. Hopefully they would have been picked up earlier. But let's make it that point that we really concentrate on. So that was a conscious decision that if it hadn't been picked up till that point, let's teach and pay physicians and nurse practitioners to do it at that point.
Okay. So I picked up on something there, is if it hasn't been caught to that point, I imagine that if, as a parent, you're seeing red flags, you shouldn't wait to this 18th-month visit.
Absolutely. You should come as soon as you see any concern. And some of the tools that can be used at the 18-month visit, and I would recommend that parents download either the NIPASing or the infant toddler checklist that we give you references to, and fill it out yourself and bring it in and give it to your family physician or nurse practitioner and say, look, I'm concerned about this, this, and this, or look, my kid just checks off everything just fine. So something that they bring in that they've thought about and really studied their child and said, okay, they can do all of these things, or they can't do this, is it a concern? Then the physician can fill out that Rourke baby record. Is a wonderful way for physicians to track development right from the newborn visit on. And there are specific well-informed items that they can ask about developmentally all the way through. But then we've really spent a lot of time making the 18-month questions the most finely tuned, particularly to pick up autism, but also other language and motor delays.
Cool. And those references you made are in the resource section. They're on the slide right now, but they're also in the resource section, so you can access them after tonight's webcast. I'm going to pause to take a question as well, because they are flooding in. What are my risks for having more children with ASD? What are risks for my other children's children? Have you gone that far?
So that's the second level. No, we haven't gone that far yet.
Okay.
They're not as high as for siblings.
Okay.
We know that, but we don't have really good figures for that sort of second degree yet.
Okay, so I guess it's another 8 years before you'll be getting to those numbers, right? Okay. we've talked a lot about the importance of early diagnosis, more importantly, early intervention. And I want to make it clear to those on the webcast that this isn't just that sort of pre-18 months. We're talking anything between 2 and 5 years, correct? Okay. So now let's talk about some intervention strategies, okay, for our audience. What are some prevailing best practices for interventions? Where can you find those?
Well, I think the best evidence up to this point is about the Early Start Denver model, and this is an article that Jerry Dawson published back in 2010. It's been followed up by a series of articles, often coming from Sally Rogers and Laurie Vismara, all in California at the Mind Institute. And the methodology, what they actually randomized in this trial, it's the first time we had anything like this in preschoolers. They sort of pulled bits of evidence that had come from different research studies looking at one little thing, like joint attention, or just the early language markers, or just specific behavioral kinds of strategies. And they really incorporated all of what they had evidence for into one lovely curriculum, and then very well-trained people delivering it. It is by far the best model that we have. It's obviously expensive and there's a lot of things involved, but there's a lot we can learn about it in terms of best practice.
On the topic of best practices, let's get into stuff that parents on the line can actually do. So we started on red flags. We started with communication. Can you talk about some best practices for interventions on communication?
So a lot of this started to come from pivotal response therapy principles, and these are being used by Dr. Susan Bryson and Jessica Bryan here in Toronto. Susan's out in Halifax with the Social ABCs program that's currently having a randomized controlled trial in our siblings starting from 15 to 24 months. So it's really, let's see how we can get the child to communicate by making something incredibly enticing for them. Okay. So we try to get their attention, we follow their lead, we see what's motivating, we take any opportunity, we reinforce any sound that they make to communicate back to us, and it's very, very fast response. So you have to be right there with the child. You're trying to understand anything that would hold them back, that would make them annoyed, that bothers them. So you're trying to understand if they're frustrated, do they not have a way of communicating? So you'll see all children have terrible twos. And I just, a little anecdote, my grandson, who's 2.5 and was a little language delayed at first, just learned to say, "Mummy always comes back," and his temper tantrums in going into nursery school have just gone right down as he's been able to give that message. If kids don't have a way of talking and communicating, then their behavior will be worse. So if you see difficult behavior, it's your job as a parent to try to figure out what could he not communicate. That's the most likely thing that's going on. So trying to reward any chance of communication, and then trying to see if you can suggest ways that they can communicate by giving you something or by gesturing or whatever. So it's, if a child loses interest, it may be that they have no way of telling you what they want, or they don't have the language to do what you want them to say. So I think that children will develop words at different rates. The things you shouldn't do are to put too much pressure on them to come out with words.
Right. I was going to say, as a parent, I'm a parent of a 5-year-old myself, and you always want them to. You always, whenever you're working on anything, you just have this. You just want them to succeed. Right. So I imagine that parents in these scenarios, watching our webcast, reading these documents, there's probably some things mistakes they fall into in trying to improve communication.
And some of our children will pick up a little phrase from, Toy Story or something. And there was one that I was trying to think of, and I can't get it. Darn. But and they'll come out with the script, and that could be annoying. Don't say that you've said that 10 times already. But if you can take that little script and make it into something meaningful, or take a word out of it and make it into something meaningful, then instead of a kind of negative experience, it becomes a positive experience. Because they're glad that you said it. So not scolding, not waiting too long, you want to give them some time to respond, but you don't want to make it painful, and that'll turn them off. And not saying, "No, say this," or "Say that, please." Please means nothing at that stage, other than something eventually they know pleases you. But so you really want to try to keep it at a level that the child is getting it. Yeah,
we used to say a lot to my son, use your words and stuff like that. Is that the kind of thing?
For an older children, that's fair enough. But for an 18 to 24-month-old, use your words is way too abstract.
Okay.
Later, yes, definitely, once they know what using their words is like and they know what the concept of words is.
Okay. So, like red flags, the next one we went on to was playing. Can we talk a little bit about social play strategies that you would for intervention?
I think the big thing with social play is just making life fun. Just spend time doing things. When you're bathing a child, play games with the water dripping. Do it lots of times. Get them having fun doing it repetitively, and then wait and see if they'll, at what point will they look at you? Why don't you keep pouring it out? What'd you stop for? Just making everything funny. You're changing the diaper, get them nice and clean, and you're tickling their tummy, and whatever. It's things that make just the day to minute interaction, having a good time. Kids love peekaboo, even just simply doing this, even in a restaurant where you're trying to entertain them when the food isn't coming quickly enough. Just that little thing can get a kid laughing and giggling for 2 or 3 minutes, and that can be a long time in a difficult situation. So the other way is through songs. Kids love songs, and leading the way with actions in songs. A great way to work on motor movement, on rhythm, on words that they're saying that music may facilitate. All those kinds of things just make life and social interaction fun. And the bottom line is you want children to understand that having a social interaction with you is way more fun than just doing some little thing repetitively with their truck by themselves.
Which is where those on the spectrum would gravitate towards.
Exactly. And many parents will say, well, he seemed to be happier when I just left him to do his own thing, and they don't want to disturb him or cause an upset. So you have to find ways of getting in there with him, and sometimes it will be a bit disturbing at first, but then you can get him to learn that, hey, it is more fun to do it with Dad.
And we're calling these intervention strategies, right? So it's probably is important that they get used to the idea that they're intervening on something that isn't healthy for their child.
Yes, that's right. Yeah. Getting them out of their own little sphere and getting them understanding what social interaction is like is what you want to do.
For sure.
And so intervention almost makes it sound, too pie in the sky. It's just teaching them about ordinary daily activities that socially can be fun to do together.
Okay. On that note, what goes along with play are toys. I imagine there's some toys that are better than others, and there's ways of interacting with toys that we want to promote. Can you talk about some of those strategies?
Well, I think cause and effect toys are always great. I think that some of the toys have too many bells and whistles, so they can be visually distracting, they can be auditorily distracting. Elmo, where a child just goes to turn on the button every time instead of thinking about, oh, here's Elmo, hi Elmo, do you want to drink, Elmo? All the things that you would do with just a stuffed animal, far more social than just repetitively turning that button off and on. So I do have a thing about those, especially cars and toys that always say the same thing, because we want them to get away from that and use a lot more different language. So I would take the batteries out of those kinds of things and just concentrate on the toy as something that you can interact with and pretend to do things with.
So it's almost like scaling back a little bit the technology associated with the toy.
And that's hard because kids in the spectrum love technology.
Right.
So, you have to have a balance.
Right. Okay. Does reading fall under toy play in your consideration?
It may not be toy play, but it's certainly under social play.
Okay.
But yeah, books, you can make them into toys, lifting the flap, closing, hiding, pulling the thing back and forth, even just playing with, oh, no, don't look at that page yet, look at this page. It's just all in how you interact and talk about the characters. The big thing with reading is to keep it at the child's language level. So 1 or 2 words on a page may be more than enough. It's interesting also because some children who are going on to have ASD love symbols, and they will go out of their way to read the words, and they don't want to think so much about the content or the pictures or talking about it.
Okay.
So if you see a child that's driven just to read the words, you think, hey, wait a minute, let's make this more fun. So sometimes you almost have to discourage too much of a focus on the symbol and try and get the meaning and content and the playful kind of aspect from it.
Okay. Everything you're talking about with social play and that requires a lot, it's a lot of one-on-one parent and child. And I've heard you say before, it's getting down on the ground and that sort of thing. So when it comes to toy play or reading, again, parents are going to want to do what they hear you say and what they read. What are some things that they should be staying away from when it comes to this? Things that parents might do wrong when trying to intervene with toy play?
Well, I think the big thing is when you're trying to play with a character and you're trying to get a kid's attention, there shouldn't be any television on in the background or video games, and your iPhone is turned off and out of your sight. You can't hear a buzz even. I mean, you really want, even if it's half an hour, even if it's just 15 minutes in a day, where you have no distractions and your child knows that they have your full attention. That's probably the biggest issue. And then it shouldn't be at that point with anything electronic, and it should be with toys and games where you can go back and forth. You can learn to take turns. That's why cause and effect toys are such good ways to start out. But nothing that's too predictable, and trying to change. If a child wants to do it this way all the time, sort of push to get a little bit more variation and then let them go back to the way they were doing it.
Okay. Now, we live in Canada, and this is Autism Ontario webcast, in a publicly funded healthcare system. Are there intervention services available to parents that are publicly funded?
There are, and we certainly recommend having every child who gets a diagnosis referred to the provincial IBI and the ABA services. So the intensive behavior intervention is the program that gives a lot of hours of very intensively delivered intervention, which was really developed to try to get the child's thinking skills and attention skills and learning skills up to the point where they really could benefit from all the learning experiences in their environment, and behaviorally get them away from things that would interfere with that. And some kids are much harder to get to focus on learning and social opportunities. And then, so that's the most intensive for the most severely affected children in our group. And then you have the ABA-based services. So those are services using behavioral programming and principles of applied behavior analysis to teach children social skills and behavioral skills and communication skills. And those are available to anybody at any level of ASD diagnosis. So everybody should get onto those wait lists. There are problems with eligibility. There are varying wait times for all of the programs, so you have to be aware of that. While you're waiting, because that's the biggest parent frustration that I hear, you want to really push early intervention services run by infant development programs. There's some great programs out there. You push for as much speech and language pathology input that you can get, the Hand in More Than Words parent coaching kind of program, and their book and their videotapes are all really good resources for parents. And then you have many OTs, often occupational therapists coming into nursery schools or resource centers, some of them coming into the early years centers. Any play-based programs, there's a variety available, and the early years center is actually one of the best places to find out about what's in your local community. They will know the resources. Now,
I know this because I have a 5-year-old, but do you find early years centers generally in schools, or?
Some of them are in community drop-in centers. They're in many different places in different communities.
Okay. Well, there's a few red flags in something you said there to me, and you talked about a wait list. At what point does ASD generally get diagnosed? And how long are these wait lists for the ABA or the IBI programs?
Yeah, so even sometimes when a child has red flags noticed at 18 months, they're not seen by anybody for a definitive diagnosis till 2.5. It can be as long as a year, although many places have been working hard on wait lists and have got it down to 3 or 4 months, which would be the kind of goal. But I think it's more important to get intervention going than it is to wait for a definitive diagnosis. So if you had noticed red flags, go to your local resources and try and get all the input that you possibly can while you're on any of those wait lists. That's the bottom line in terms of...
So as a parent, it's my not my responsibility, but I can go and do that without my physician sort of dictating it.
Yes, absolutely. Okay. You can call preschool speech and language yourself. You can call in early intervention yourself. You can talk to your daycare provider. You can talk to your early years center people, and they will tell you what's available. And you can read. There's lots and lots of things to read. The First Words website that's on the list of resources is a great set of videos, so you can see what's typical, what's atypical, and so you can really see for yourself firsthand, does my child meet that or not? If you're seeing the atypical, then go see what you could do to try to influence that, if you've got the time and energy, and I know that's often hard.
I'm going to go off script here because a couple questions are related exactly to what we're talking about. So up until what age is IBI most effective?
There's most evidence to support an IBI, so that's aiming to improve the cognitive learning kind of skills and learning readiness skills. It's most effective up until 5 or 6. Okay. The behaviorally based methodology of dealing with intervention should go on and on as long as you need it.
Okay. What help would you suggest for someone who's waiting for IBI programming?
Well, I think that the speech and language input is a big one. I think some occupational therapists are tremendously helpful in dealing with kids whose sensory interests are just causing tantrum after tantrum after tantrum because they don't want to leave them. So I think occupational and speech therapy. And then there are a variety of people who are really good at teaching play, really good at teaching how to use behavioral problem solving and interacting with your child. So there's a big variety of programs out there. Okay. The unfortunate part is many of them you have to pay for them, and that's what we have to change.
So I understand that there's a number of medical complexities that go along with ASD. Can we talk to those for a bit? Mm-hmm.
We've been really learning so much about medical care, and we've been learning that a lot of medical symptoms have been passed off as, oh, that's just autism, without really appreciating what could be going on underneath. And Autism Speaks for the last 5 years has been funding this autism treatment network, and we've had a site in Toronto, and there's another one out in Edmonton in Canada, and then 15 other sites around the country. And the things that we've been documenting that occur much more often than you would expect in typically developing children are seen on the list here. So there's the gastrointestinal ones. The commonest ones are reflux, quite often in the older kids, so really bad gastroesophageal reflux disorder, awful heartburn, real inflammation of the esophagus, sometimes actually ulcers. And we've wondered why kids were banging their head. And we say, oh, self-injury associated with autism. And then we look down their esophagus and they've got a big ulcer. It's awful. And then you can get both 2 or 3 loose stools a day, or you can get some of the worst constipation as a pediatrician that I have ever seen in my life. But we have great ways of dealing with it now. The PEG flakes, the polyethylene glycol 3350, PEG 3350, or Laxaday. It's sold in some of the drugstores. Almost said a brand name. Or you can buy it in one of our big box stores that has a very big pharmacy in a big container. And many children just feel so much better if you get them having a regular bowel sort of pattern. And their gut just has to be so much more comfortable. And then we get into how many of those things come from nutritional difficulties, very, very narrow food intake. We had one boy that would only eat small, round, white bagels and partly thawed blueberries for probably over a year of his life. So, I mean, his gut just couldn't work properly, let alone how he felt because of the nutrition. There's lots of debate about gluten being a problem. There is not, from what we can tell, a higher incidence of celiac disease. You get the same as you do in the regular population. It can overlap sometimes. There are some children that may have some irritable bowel symptoms, and some of that might be made worse by gluten. There's certainly some children I've seen that just seem more settled and less abdominal distension when they're on some of these restricted diets. The big thing is only to take one thing out of the diet at a time if you're going to actually take things away, and really hard to take things away if they only eat 2 things to start with. So you always have to sort of try to go through this in a systematic way so you know what you're doing and never do more than one thing at a time. Okay. The other piece about the gut kind of comfort is if you're uncomfortable, it's going to interfere with sleep, as will hunger. And we don't even know if hunger is experienced the same way in some children. So sleep disturbances happen in at least 30% of children with autism. It seems to be worse, especially restless legs in kids who iron is low, and again, partly related to nutritional problems. Many of them have quite low iron, so that should always be checked if there's a sleep problem. There's a study going on, Toronto Society, for looking at the actual correlation between sleep and low iron levels right now, funded by Autism Speaks. And then the other thing that can interfere with sleep, that's both falling asleep and awakening during the night, is epilepsy. And so in the typical cognitive level kids and Asperger kids, the kids with Asperger syndrome, the epilepsy rate is about 8%. When you get down into the more cognitively impaired group, you can go up to as high as 30% in some studies who will have at least one grand mal seizure by the time they're 30. So we're always looking for signs of seizures, staring spells, especially that you can't break the child from and sort of interrupt and get their attention to something else. Early morning wakening, especially if they wet themselves at that point, very high chance that that could be a seizure that needs to be looked at. So epilepsy is a big medical problem in the autism world. And if the seizures go on and are poorly controlled, usually autism symptoms become more severe over time in those children. So you really want good control, early recognition and good control. And then there's the whole genetic piece in terms of medical complexity, because we're seeing soon, I think we'll have up to about 20% of individuals where we'll have some sign of something genetic that's different, either pieces of genes missing or duplicated. Sometimes it's inherited, even though the parent may have that same difference and are not autistic. Sometimes it's just out of the blue. If it's out of the blue, then we can give more advice about genetic counseling, because then the recurrence risk won't be as high.
Okay. So how do we use this information? Are these red flags for parents to look at? Are these things that you want parents to know about to ensure they're getting? It's more of that, right?
I think it definitely is. Parents need to think about it. Think, does this make sense? Does this symptom apply to my child? Now I need to go to my medical practitioner and say, there's this association in autism. Parents have taught me more than anybody else about what autism and the things that go along with it are. So I like it when people come and say, you know, I read about this, there's this association. If you heard about it, I may not have heard about it, but I will recognize it from then on. So it's a team effort.
And these are fairly new realizations.
Absolutely.
So there's a good chance your physician does not know this. Okay.
More and more do, especially, pediatricians and especially people that have been exposed to the autism world. But definitely many family doctors might not have recognized how high the association was.
Okay. We've got a lot of questions coming in. We're getting to that time, but one thing that we promised to talk about, and I think that we should, is we focus much of our discussion on early years, early interventions, and whatnot. But once you get past that point in time, what are things we should be focusing on to, in your words, build competence?
I think that for me, just competence is the thing that I keep coming back to all the time. How do we help individuals who, by the time they're 7 or 8, know there's something different about them, know there's some things that they can't do that other kids can do, and why, and start asking why. And for many, that's the stage when they share with them what an autism spectrum disorder is, or they wait till they say, what's different about me, and then it's your opportunity to tell them. But you don't want that to be oh, well, I've got something wrong with me, so, I can just sit back. It's something that you say, we're working on this. These are things that are harder for you. Everybody's got some things that are harder, but you've got lots of things that you can do well, and we're going to teach you the skills that you're having trouble with. So every child, I think, should be in some activity outside of home. And you try to find something that the child will enjoy, whether they're going to be a star in it or not. We have stars in many different areas, but unless you practice, you'll never become a star. And so one activity that you think matches the child's interest. And then adding new skills. Every year, every few months around home, new skills that they can say, oh, I can do that zipper up now, and I didn't used to be able to start it. Or I can have a shower independently now. I can get the water to the right temperature. Hey, you couldn't do that last year. Isn't that great? Now you can do it this year. I have a thing about having kids, once they have the motor skills, to make some attempt to help with a family meal. And by the time they're teenagers, hey, they're the ones that's going to do Friday night. Make it as easy as possible. They do the pizza for the family on the Friday night. Yeah. They learn to make the salad. It's just a matter of opening the bag of lettuce and dumping some things in, but they made the salad. So wow, that's real competence. I see other kids getting more independent. Maybe I'll eventually get a bit more independent too. Learning to tell time is critically important, and it really brings the anxiety down when kids can follow a watch and say, okay, I know that I've still got 10 minutes. so I can relax. I'm not worried that somebody's about to jump out and tell me that I should be somewhere. And we found that if the kid has a schedule on their desk at school, and on that schedule are like 15-minute time intervals, and they can check with the clock and know when they're supposed to change, that's far better than worrying about somebody soon about to tell them something. Or you can get those clocks where the red gradually increases so they can see the proportion even of the hour that's left. Very, very helpful in terms of saying, okay, I've still got some space left. I don't have to worry. And then the other thing, independence in the community, learning to deal with money is fabulous. I mean, some of the kids have great money skills and they're mathematicians, but others are dreadful and they feel totally incompetent. Like if you go in the store, they're either very, very anxious about going up to the cashier or they really worry that they'll make a bad mistake. So working on, if they can count to 10 and they have one-to-one correspondence up till 10, counting out $10, then they can be going to the cashier and buying the 3 liters of milk and know that they're going to get at least $3 or $4 back. And so sending them up there, practicing it ahead of time, working on it so they can go into the store and go, right, get the bags of milk, take the $10 bill, go to the cashier, come back and count out the change. Don't worry about the small change at first. We can stop worrying about pennies now. Yeah. But really just worrying about how many dollars and being able to count it back and, whoa, I'm really growing up. Maybe I could look after my own money at some point.
So I imagine that none of this happens magically. Parents need to plan this,
over and over and over.
Right. So the next broadcast on the 19th is about individual education plans, where it's about looking at, whether it be 6 months or a year, what we're going to cover. Do you recommend that parents on a 3-month, 6-month, yearly basis are making actual plans for what competencies they want to see their child achieve, or?
It's been a real privilege for me to see some families almost every year, and within the Autism Treatment Network, we've been doing that systematically. And I have found that it's a time to reflect what has actually been accomplished in the last year, but now let's set some goals for next year. So, and many families over time have kind of saved up to say, okay, we're going to reflect on this and we're going to plan this for next year. Within the educational system, the ideal thing is for families to have as much input as possible to that individual educational plan, and in the same way say, well, this is what was gained last year, now this is what we'd like to see this year.
Yeah. Really stepping onto that collaborative approach.
Absolutely. It's all teamwork. It's teamwork around medical care. It's teamwork around educational care.
Great. So I'm going to put my attention to your questions. A reminder to anyone out there who has not yet submitted a question or comment, you can do so at any time using the Ask Question box. We're going to go through our formal Q&A period now, and we've got about 14 minutes for that, so keep the questions coming.
Could I just draw the attention to one slide that we skipped over? The toolkits for the various medical problems are on the Autism Speaks website, and you have to go through specifically looking for toolkits. Okay. Some of them associated with the Autism Treatment Network, and some of them leading to like pediatric supplements where there's a lot about some of the gastrointestinal problems and things. So I just put that in there so that you remember, look up Autism Speaks, and then remember to look under Family Services and Toolkits. I think it's a little easier to go straight to Toolkits now once you're on the site, and you can download some fabulous information on toileting, on disruptive behaviors, on the dentist, visit to the dentist, on sleep, fabulous sleep program. Wow. Some of our Girl Guides groups have been actually making us little sets of these little tokens that we use to reward children who have stayed in bed all night, or we even had a child lately who asked a parent to leave because they wanted the reward. Don't stay with me any longer. I want to be independent and get my reward in the morning.
Whatever motivates them, right?
Absolutely.
Well, I hope you can still answer these questions, because a lot of this stuff is exactly what people will find in there. But here's one. Our 3-year-old son is nonverbal. He makes expressive sounds, but not real language yet. And PECS has been recommended. What do you think of PECS, PECS?
So picture exchange system, I mean, if a child really doesn't understand the process of communication, then from my pediatric perspective, and some speech pathologists might find holes in my argument, but the way I understand them is that if you then give them a card that has some kind of a symbol on it that they know is associated, that they learn is associated with something, and they give that to you as a form of communication, then that will facilitate them understanding that, oh, I give that and I get something back. So it's teaching the to and fro of an activity. The trouble is that sometimes if a child doesn't have the understanding of what the symbol is that's on the card, then they're not really learning the content other than just that giving process. And so sometimes understanding, do they know what a picture is? So can they associate a photo with a cookie? So if there's a photo of a cookie and they want a cookie and then they give you that card, then they're getting the understanding of, oh, you understand that, I understand that, I can get a cookie if I give you that card. But it should be allowing the process of communication to be developed. It should never be the be-all and end-all, the end in itself.
The replacement of
exactly,
trying.
Of learning, trying to vocalize.
So this question is, maybe just to handle specificity, if you even can, this question is about a 3-year-old nonverbal. Mm-hmm. Is 3 too early to take that step? Is it something that you would like to see done earlier or later? What are your thoughts?
We've had a bit of a sort of a generic, everybody who's not talking should use PECS. Okay. It's just not that straightforward. You have to know the child. You have to know the stage they're at in understanding either a symbol or a picture. Maybe they're not even there yet. Maybe they actually need to give, a representation of a cookie that looks like a cookie, just a functional cookie as opposed to the picture. So it's different stages of cognitive development. So you really need, I think, a very experienced, hopefully speech and language pathologist to make that decision about when they're ready.
Okay. Well, hopefully that helped. If it didn't, or you want a follow-up question, please send it through. Dr. Wendy, they said hi first, and they said, I would like some help on how to help my son Andrew, who has autism. He is very constipated all the time, and he is 7 years old and is still not toilet trained due to him being constipated most of the time.
That's absolutely right.
Yeah.
Once you have a history of constipation and your gut gets stretched, the actual messages don't go from the gut to the brain any longer. And so they can have overflow incontinence. It can be watery, it can have gory details after dinner, or it can be just impacted. So what you really have to do is both look at diet, but that's the kind of situation where I would start PEG flakes at a low dose, a teaspoon morning and night, mixed with a quarter of a cup of water or juice, nothing milky or it curdles, and just gradually increase the dose. If you give too much too quickly, you may get cramping and discomfort, but then you have to go into a whole bowel retraining program, and that's where the toileting toolkit on Autism Speak's website is really helpful. But often that toolkit alone, unless you use the stool softer, there's nothing habit forming about PEG flakes or Laxaday if you buy it in the store. You just have to get the system sending messages to the gut. Then the other thing is we're most likely to get a message from our stomach to our gut, empty me, 15 minutes after your biggest meal.
Okay.
So we call it the Gastrocolic Reflex. And so if you've had soup, if you've had porridge in the morning, if you've had lots of fluids, particularly warm fluids, it's more likely that a message will go to your gut to evacuate. So if you're going to take a child regularly to the toilet, do it after breakfast and after dinner, and do it about 15 minutes after they've finished their meal. So there's most likely to be some message going there to do something, because it's very discouraging to just go and nothing happens. Yeah. In the worst case scenario, to get it started, you may have to use some suppositories. I hate to do that though, because it's incredibly intrusive, and especially for kids with ASD, with all kinds of sensory issues, you do not want that battle. So that's where we have really, I think, changed practice then in terms of the PEG flakes. But I would also increase the fiber if you can. I know picky kids, that's often hard, but we hide natural bran in hamburgers, we hide it in cookies, even with extra chocolate chips, whatever it takes, increasing the fiber if you can, being I can't believe how creative some parents are in getting the natural bran, I swear by. Just those very, very fine little bran flakes are another great way to increase the fiber in anything you can hide it. Sauces, puddings, cereal, anything.
Okay. My 18-month-old loves bath time, but cries and screams every time that water goes on his face or head while rinsing it. He often cries while putting clothes on as well. Could that be a red flag?
It could be if it's prolonged. I often say to think about sort of the length of the crying. So most 18-month-olds will cry when water gets on their face, or especially they've associated the water going on with the shampoo maybe burning their eyes. So just that alone isn't enough. If it starts and then an hour later they're still crying, that's a red flag. If it's a couple of minutes, Mom, don't do that, I don't like a cry, and it's over and you can distract them in 2 or 3 minutes, then I wouldn't be as worried. That's a very, very typical thing for 18-month-olds to really fuss over.
Normal reaction. And I agree. I mean, I think my 5-year-old still has some problems with it sometimes. But the one here that may be different is while putting clothes on. Is that abnormal?
Well, the clothes, if we think about it, a lot of T-shirts have very tight necks. Right. So for some kids, they've learned that, their ear really hurts when Dad yanks that T-shirt on too hard. Yeah. So they may have associations of actually, especially ears hurting, or that tight pull down over their face. And when something's going down over their face, they can't see what's going on. And that's really scary in that situation. So the face is covered. So 18-month-olds will fight over clothes. So most of the time I would not be worried about that. It's prolonged, and if they're not learning and really thinking, does it happen more when something's going over their head that's hard to get on?
Okay. A couple questions here about medications. First of all, a fairly big one here. Are there medications available to treat autism?
It's a great question. Nearly all of the medications that we use to help with particularly behavior and anxiety in autism are medications that we have kind of borrowed from other disorders. There are almost no autism-specific medications yet. There's some under development. There's some very interesting ones, like the sort of what we call the social hormone oxytocin that studies is being done on. Many studies are being done now. But really, most of the medications, it's either for attention or anxiety or aggression. So it's nearly all things that have been developed and tested out more in other populations rather than just autism. They're not autism specific. We're hoping, especially through our genetic studies, to get some clues about what receptors we could target medication toward. But first we have to get the receptor and the protein. That's why we put so much energy into our genetic studies. I hope in 10 years we'll have a number of really autism specific treatments.
Well, in the meantime, we have a follow-up here about specifically, this is probably a parent who's been looking at anxiety medication. Mm-hmm. Specifically, speaking about anxiety, can you speak about medication that you've known help, what's worked? Does anxiety medication work with autism?
Mm-hmm. There are some children who will have a definite decrease in their anxiety symptoms with particularly some of the serotonin reuptake inhibitors, so the selective SSRI medications. So things like Zoloft, Prozac. Most of them have been tested on anxiety and depression, not as much on autism. And it seems in autism you can get a very high response rate to a placebo drug. So like sometimes the placebo rate is 40%, and it might be great if you got a drug response of 40, 45%. That's not going to come out as statistically significant. No. So it's very interesting why we have that kind of high placebo rate. So Celexa was studied, and the drug rate was no better than placebo. We did some studies with Zoloft, and parents swore that was just awful adverse response in 3 or 4 cases, and they were on placebo. So, you can get it in both directions. So it's hard to study, but there definitely are children with kind of palpable anxiety. It's really hard to measure anxiety in autism. Sometimes what we think is anxiety is excitement. Yeah. But if they're really anxious, then the serotonin reuptake inhibitors can help. But, it's interesting, there's really more evidence to support behavioral techniques like cognitive behavior therapy, and now we're starting to think about mindfulness meditation and combined with cognitive behavioral therapy, there's a higher response rate to that than there is to any of the medications that we've tested so far.
Wow. So don't shy away from anxiety medications because it could help.
No, it can help. You just start very low dose and you go up very slowly. I don't use anything like the doses that psychiatrists would use for treating severe anxiety disorders or depression. Okay. Very, very low doses. People with autism seem to be very sensitive to dose.
Okay. How common is it, and we're switching gears totally here, how common is it to have a second or third diagnosis with someone with ASD?
It's almost a standing joke that when we're getting referrals that we get a parent who's saying, my child has been diagnosed with ADHD, OCD, bipolar disorder, conduct disorder, oppositional defiant disorder. Do you think they might have autism? So it just happens all the time, and often an inexperienced clinician who hasn't seen a lot of ASD, they may be wonderful in treating depression or whatever, and they're not familiar with ASD. If you add up all the symptoms, a child with ASD who's sticky and wants to stay at doing one thing and basically ignores you when you tell them to do something else, that kid will be called oppositional defiant. But it's not the same as a kid that says, I'm not going to do what you tell me and I've made up my mind. That's oppositional defiant. That's not usually what you see in autism. It's, I want to keep doing this thing that I'm obsessing on and I feel really strongly about it. Anxiety, yes, we know that they coexist and shared wiring in the brain. Obsessive compulsive disorder often coexists in other family members. So, and sometimes if you have OCD and you marry somebody with anxiety, then you really get it together, and then the symptoms get all mixed up. So that the coexistence of many of those things absolutely takes place. And I see children developing signs of OCD sometimes as teenagers where the repetitive things they did as younger children were clearly autism. Now it really looks like obsessive compulsive disorder. Bipolar, it's still a bit up in the air, but any family who have any neuropsychiatric disorders will be more likely to have autism in the mix. And I think that's because there are hundreds of genes that seem to lead to any of these disorders, and many of them are shared. Many of the genes for ADHD are the same genes that seem to put you in a vulnerable position for autism. So obviously, many people with autism will share the symptoms of ADHD because the same genes are acting.
Okay. Got time for one more question. And, this is a parent who is looking for suggestions if they can't find their child's motivator. It's not motivated by anything that anyone has been able to find. Is there strategies for finding the motivator?
You know, if you looked at our wonderful speech pathologist's office, there are stacks and stacks and stacks of toys. She's better than anybody else at finding them. But why? Because maybe out of the 150 toys she has, there'll be one toy that will get the most difficult kid to motivate. So it's trial and error and a huge amount of ingenuity, going to toy libraries, signing things out. There may be an intrinsic low level of motivation. On the other hand, maybe you really haven't demonstrated just that one thing that they really like. Now, if it's a kid that's obsessed in video games and then not interested in doing anything else, that's a little bit different. And once you've got them into that obsession, it's really a challenge to break. You have to find something very vigorous and very enticing to get them away.
Okay. Well, I know there's more questions, and as we mentioned, we are going to get back to those questions we weren't able to answer live tonight through an FAQ. Before we close out, I wanted to give you an opportunity to give us some conclusions and some final thoughts.
Well, I think that we're learning a lot. We're learning a lot about autism. Families have taught us an awful lot. We've made an awful lot of progress. We know now some of the things that really can help us put really good early intervention into place before the diagnosis. What we have to find is a way in our broader healthcare system and our intervention system to be able to build those things in efficiently and in a way that are going to work effectively. But we have to work together to try to facilitate facilitate the early detection of those red flags. And our overall goal, as we do all of our research into behavioral and neurobiological factors that are involved, our goal is to provide a continuum of integrated care from the first red flags being seen right through into adulthood, so that we get better care and a better quality of life for the individuals that are affected and for their family members, their parents and their siblings particular.
Well, that sounds like a good goal, and I look forward to sitting across you maybe next year and hearing about the improvements in the continuum.
Great.
That's all the time we have tonight. As mentioned off the top, the questions we didn't answer, we'll get back to you through an FAQ. We hope you enjoyed tonight's broadcast, and just a reminder that we have another one coming at you on March 19th. It's Individual Education Plans, the Basics, and Transition and Safety Plans. If you know someone who you think may have benefited from tonight's broadcast but wasn't able to attend, or you yourself want to go back and review a lot of the great material that Dr. Roberts shared with us, this event, along with the first event from our series, will be available on the Autism Ontario website very shortly. Thanks again for all of the time you've taken with us. On behalf of Autism Ontario and myself, I'd like to thank you for your participation this evening. We look forward to seeing you on the 19th and at future Autism Ontario events.